All right, so I'll kind of start the lecture. So it's going to be approached to inpatient dermatological conditions. So I'm going to start off just with kind of going over how to describe dermatological conditions, and I'll just give you kind of specific manifestations, and then we'll go into just common inpatient diagnoses, and then really how to approach them, how to manage them. All right, so starting off, what would be your guys' descriptor of this on the left? What would you say this? You can give as many words or as little words as you want. It doesn't matter to me. But I am working for a specific word.
Maculopapular.
Yeah. So the thing I was looking for right here, and that's perfect, because it is maculopapular. So this is a macule, this is less than 1 centimeter, and it's blanching, right? So say if I gave you this patient, but the patient has high-risk sexual behavior, and also came in with like hair loss as well, lymphadenopathy, what would you be concerned about? Syphilis, right? So just going over, and specifically secondary syphilis, just going over the manifestations of that, other things to look for, canuloma velata, which is actually, this has a really high spirochete burden right here, and that's present usually in mucous membrane, so it can be in the mouth, can be on the perineal area as well. The typical moth-eaten alopecia is a typical finding you may see. And the other one is going to be lymphadenopathy. And this lymphadenopathy, classically, it's going to be epitrochlear, but you can really see in the cervical areas, inguinal areas as well, so things that you look for. The really devastating manifestation, the things you worry about, and why we screen for syphilis so heavily, especially in patients who have T-cell immunodeficiency, because they can progress to this much more quickly and much more commonly, is going to be neurosyphilis. So common manifestations that you'll get tested for neurosyphilis is meningitis, uveitis, anterior uveitis, panuveitis is more common than really the other eye manifestations, but really anything can occur. Otosyphilis, so people may come in even with hearing loss and dizziness. And the thing that you really, really look out for, and this is especially in common with HIV patients, and there's a big prevalence of syphilis in HIV patients, is going to be meningovascular syphilis, when syphilis actually causes vascular inflammation and can lead to stroke and permanent disability. All right, so how about this rash right here? What do you guys call this? Doesn't show up as well as I would like on here. So maybe a descriptor of it. No, I think any description is good for rashes. I think that's totally fair. I will say it's not a bruise, though.
Circular.
It's circular.
Well demarcated.
Well demarcated.
Plaque.
Oh, close. Patch. So it is the patch. Very close. So patch is going to be greater than 1 centimeter, and it's going to be flat. We'll get to plaque in a little bit. So flat, greater than 1 centimeter. Now, say if I said, this is the patient I saw actually in the ED. This guy came in, he was treated with sulfa, and then a while in the past, and he said he had this weird rash in the exact same area, treated with sulfa again, and got this rash again. What do you guys think this could be? Fixed drug eruption, great. And fixed drug eruption, I mean, I've seen once or twice. It's not completely uncommon, and that's a typical history that you get. Usually with antibiotics, Bactrim, penicillins. It's going to be pretty much the common reason for them. Allopurinol can do it as well, and some of your anti-epileptics can do it. But it's going to be a patient say, oh, I got this before. I had this weird rash in the exact same spot. They're exposed to that drug again. They get the same exact rash. It can be truncal, which is here, but it also can be acral, so it can be on the feet. Genital, which can be very confusing for an STI, and this is how this patient came in, and I thought he had herpes at first. It can be on the face as well, which can be confusing. But it's going to be this dusky patch that shows up with re-exposure to a drug.
Is it painful?
Non-painful. Yeah, non-painful. And they usually really don't have too many systemic manifestations as well. All right, so that's patch. Next one, what would you call this? So I heard pustular, very, very close.
Umbilicated?
What's up?
Like umbilicated? They have a little...
Oh, it is umbilicated. It is umbilicated. What does that make you?
Papules.
And it's an yeah, papules. There's something, Amanda, good job. So this is an umbilicated papule, and that should lead you to one diagnosis.
Molluscum.
Molluscum, yes. So this is an umbilicated papule. It's raised, less than 1 centimeter, and this patient had molluscum. Next one, Amanda, what would you call this?
Like those are scaly plaques, right?
Perfect. Yep, plaque greater than 1 centimeter. And then this one's not too hard, but what do you guys think this is?
Psoriasis.
Exactly. So this is psoriasis. These two things, especially with explosive psoriasis, can be a sign of an underlying disorder. Does anyone know what it is? Yes. That's really testable, and something you should really know is the skin manifestations of HIV. So always think about viral infections. So they're at higher risk for HSV, VZV, but molluscum is a viral infection as well. So they're at risk for that too, and especially if they get disseminated molluscum. There's something on the this is a really hard one, so I'll just give it to you. There's something on the differential of umbilicated disseminated papular lesions in an HIV patient, and it's actually cryptococcus. I've seen this diagnosed actually from derm biopsy, it's cryptococcus, and those patients always need an LP to rule out CNS disease. This is explosive psoriasis, really HIV gives you alteration in T cell function, and this is kind of a sign of that when these patients get explosive psoriasis. Also get another one, explosive seborrheic dermatitis, a really severe sebderm, which is due to a fungal infection, so that T cell immunodeficiency also puts them at risk for that. So things to think of. Another one to think of in HIV, does anyone know what this is? Kaposi's, yeah, and that's secondary to HHV8, another viral infection. Specifically, what you call these is called nodules. I don't know why it's a thing, but it is. And there's specifically a nodule is a 1 to 2 centimeter dome-shaped lesion. So when you're describing something like this, you would actually call this a nodule. There's something else that's also in the differential. Whenever you see something that looks like Kaposi sarcoma in an HIV patient, does anyone know what it is? What's that?
Bacillary entry.
Yes.
Something.
Bacillary angiomatosis secondary to Bartonella. So always something to think about. I think Michael was saying it as well, so you guys are good. Always something to think about when you see these purpuric nodular lesions in a T cell immunodeficient patient. All right. Last one, actually second to last one. How would you describe this?
Vesicular.
Yes, so clustered vesicular rash, absolutely. And I think if you said bullae too, that would be fair. Maybe these are a little bit bigger than 1 centimeter. I think you saying this is vesicular or bullae would be totally appropriate. And now I'm going to give you the history that this is a patient who came in with stasis dermatitis, and then they ended up putting like neomycin, and then they developed this really pruritic reaction with vesicles on their foot. What would you be concerned about?
TEN?
What's that?
Is it TEN or?
Just so localized only to where they put the neomycin. Sorry, I should explain that more. Yeah, it's contact dermatitis, exactly. So vesicular rash, secondary to contact dermatitis. You will get tested on how to treat this. It is in an internal medicine wheelhouse to treat this. And just remember, it's going to be high potency steroids, unless it's on very places with thin skin, which is going to be the face, the armpits, the groin area. Then you'd use something like a low potency steroid like hydrocortisone. But it's usually going to be high dose steroids like triamcinolone or Lidex to treat this topically. If it's super severe, they actually need to go on oral steroids for like 14 days. So a pretty prolonged course. All right, so that's contact dermatitis. All right, what would you describe this as? Someone said this already.
They milia.
But it's not familiar. How would you describe this rash? And I think you may have said it already. They're fluid, they're kind of pus-filled. Pustules. Yeah, this is pustules. And this is a common, actually, drug reaction. So say if this patient got treated with Zosyn maybe 2 days ago, came to the hospital, 2 days later develops kind of like fevers and this disseminated pustular reaction, what would you be thinking about? So this is actually one I don't think I really knew until maybe like second or third year residency. And then I did see it once in the ICU as well in a patient who took allopurinol. But this is AGIP, so acute generalized erythematous pustulosis is another drug reaction just to keep kind of on the back burner. Not as common as like DRESS and SGS-10. It does happen, and it's actually the one that happens the quickest from the introduction of the drug. So it happens within hours to days of starting that medication, which can be a clue to the diagnosis, and especially seeing these pustular lesions will help you. All right, last one. Old lady comes to your clinic and just says she kind of just bumping her arm on a cabinet, and then she's got this kind of lesion. What would you describe this lesion as? Yeah, ecchymosis, purpura. Yeah, absolutely. So this is like purpura, so a non-blanching rash, or you could say ecchymosis as well. Purpura is usually smaller, ecchymosis is a little bigger, so either one of those good. And then, does anyone know what the specific diagnosis in like a very stable older patient that has a little bit of thin skin, bumps their arm on something? Does anyone know what, and then develops purpura? Anyone know what that's called? It's pretty benign. Yeah, senile purpura. I actually had this on my step 3. There was a question on this. So this is actinic or senile purpura. Benign disorder. Basically, older patients, they just have their collagen kind of breaks down, so they have fragile vessels in their skin. And those vessels, when exposed to minor trauma, are just more likely to bleed into their skin. Higher risk if they're also on anticoagulations as well. All right, the thing that I see getting confused a lot is going to be secondary lesions, right? So we want all of the primary lesions. These are pathological lesions that happen due to a disease process. But I see that a lot of times people think secondary lesions are primary lesions, especially in the outpatient. So it's really helpful to just go through secondary lesions. I won't quiz you on this because I don't know. I think it's a little bit harder. But these lesions are due to external forces like scratching, picking, and healing. The first one is going to be excoriations. So in someone who has contact dermatitis, they're going to be scratching, and they may have secondary excoriations on top of this. This is actually just secondary to them scratching. If someone has pruritus without any primary lesions at all, that is a very internal medicine problem because that could be a sign of a lot of underlying disorders. Does anyone know if you just diffuse pruritus? Cholestasis, so liver disease, absolutely. On that same part, renal disease. And then I'll give you the other one. What's that? Thyroid. Thyroid, perfect. Yeah, so always checking a TSH is huge for these patients. Does anyone know the last kind of group of diseases that can cause pruritus? And it's something that you really need to worry. It's like a no misdiagnosis, diagnostic imperative. Lymphoma. Damn. Yeah, so lymphoma, especially Hodgkin's lymphoma can give you diffuse pruritus. So actually these patients will need a full metabolic workup, TSH, and also with pruritus without any primary lesions, you should get a chest x-ray to make sure they don't have any mediastinal lymphadenopathy. This is kind of the longer, what happens to excoriations over time. There's a secondary physiological reaction to the scratching, and the skin becomes thickened and hyperpigmented over time as well. So this is called lichenification. I see this a lot when I had a patient with contact dermatitis, came back and had lichenification in that same area. And like, I think the resident was still worried about ongoing contact dermatitis, but this lichenification can last for months. The same thing as post-inflammatory or post-inflammatory hypopigmentation. This can take a longer time to go away. So even if you treat the primary disorder, it may stick around for a while. That's something to always consider. The last two is scale. So scale is base, and you can say this is primary. I think that would be fair. It was, and up to date it said it's secondary, but really that top layer, that stratum cornea of the skin is just kind of coming off a little bit, and it shows as a scale on dermatological review of the skin. This can be a clue into some underlying disorders. You guys know maybe 1 or 2 diseases that can occur with a scale, like a scaly rash outside of psoriasis? What if I said I had a patient who came in, they started off with this really itchy rash in one area, And then that rash kind of went away, and they had all these little scaly lesions that popped up, these really itchy, scaly lesions that popped up everywhere else in their body. So this one's pityriasis rosea. Start off with that herald patch, and then they get these scaly lesions. And the thing that clues you in for pityriasis rosea is that these patients, something called a trailing scale. So in something like tinea corporis, the scale is going to be really on the outside of the skin. It's actually right on here for the people. So it's really going to, like tinea corporis is going to be on the outside of the skin here. But on pityriasis rosea, they have that trailing scale. So it's actually inside the primary lesions. That can be kind of helpful for your differential. Always rule out syphilis. Anytime you think that the patient may have pityriasis rosea, syphilis can, it's usually like a maculopapular rash, but it can be scaling. Even some cases, it can be ulcerative, and that's called Blues malignant. All right, last one is just a crust. So this is just secondary to exudate, red blood cells, stuff like that. This is a patient with impetigo right here. Sebum, that's another thing. So you can always say primary lesion, I think it's this, with secondary excoriations like invitation, secondary scales. That's how you describe the rash and use the secondary manifestations to describe it. All right, quick review. Less than 1 centimeter is a macule. If it's not raised, if it's raised, it's a papule. If it's got fluid in it, it's a vesicle. If it's got pus in it, it's a pustule. If it's greater than 1 centimeter, not raised, it's a patch. If it is raised, it's a plaque. If it's dome-shaped and 1 to 2 centimeters, a nodule. If it's greater than 1 centimeter and fluid fills, a bullae. And then for the secondary ones, there's excoriations, lichenification, hyperpigmentation, scale, and crust. So I think those are like the biggest ones, right? And that's the way you think about it, and that's the way you describe the rashes. You can also put a lot of other stuff on top of that, but I think this is like your baseline. All right. Anybody want to read this for me? This is the patient I had in JHAP.
A 58-year-old woman with a past history of hypertension, hyperlipidemia, diastolic heart failure, who was seen following JHAP. She recently developed this rash shown on the left. On physical exam, temperature is 100. The rash is blanching on physical exam. What is the description of this rash? And what is the differential diagnosis description?
So what would be your guys' just description of this rash?
Maculopapular.
Yeah, this is a maculopapular rash, a common maculopapular rash. And I think we see this a lot, especially in the hospital. So I think it's always good to just have a general approach to the maculopapular rash. It's very much an internal medicine rash that we should know about, know how to treat, know how to manage. So what would be your guys' differential for this rash?
Hydralazine.
The drugs, right? Yeah, absolutely. And like when it comes to drug eruptions, like the same drugs show up over and over and over again. So you said one was hydralazine. Any other drugs that you worry about in the hospital that can cause this? Yeah, so absolutely. So antibiotics and what other, so sulfas, absolutely. What other antibiotic can do it? So Bactrim's a sulfate antibiotic. Yeah, so yeah, penicillins, beta-lactam. So penicillins and cephalosporin. So yeah, actually you described that better than I did. So beta-lactam drugs. Anything else that you guys could get concerned about? Other medications?
Like allopurinol.
Yeah, so non-antibiotic sulfa with sulfa rings. So allopurinol, absolutely. The other one within this is like Lasix, hydrochlorothiazide. And then how about if this patient was like on a neuroservice and developed this?
Like antiepileptics.
Yeah, absolutely. And do you know which ones?
I want to say phenytoin.
Yep, absolutely. So it's a general group like the aromatic antiepileptics, includes phenytoin. Any others? Well, yeah, perfect. You guys got them all. Carbamazepine and lamotrigine. All right, and now getting more fancy, what is some other things that can cause this rash? That you should probably keep on your differential.
It still could be contact, like if they put some lotion all over her or something.
Yeah, that could be. I mean, a contact dermatitis would usually be more vesicular, and it would usually, I guess usually it would be to the area that was like they put on this whatever immunogenic product was. I didn't give you the full picture, but this is the patient's full body, and they didn't, let's say they didn't really put anything on their skin. But I think that's definitely something to absolutely be concerned about.
What about like a viral?
Perfect, viruses, yes. And there's certain viruses that are more common than other ones and ones that you really need to rule out. Does anyone know some of the viruses that you get concerned about when you see this rash? Yeah, so for people who are not immunized, absolutely measles. So it usually starts in the face, goes down to the rest of the body, and obviously becoming more common with less people getting vaccines for the MMR vaccines. So something to absolutely consider. Even in adults, there was a New England Journal of Medicine article about actually on a patient with measles. Can be very severe as well. You get encephalitis after it. I mean, it's no joke diagnosis. So measles, and in that same category, I'll just put rubella. Anything else to be concerned about for viruses? There's one virus that you just kind of always work up. Yeah. So absolutely HIV. How about if this patient came in with like tonsillar exudate, you felt a pretty enlarged spleen, they've been tired, febrile for a couple days, someone treated them with penicillin, perfect mono. So EBV, and then like CMV can give even immunocompetent patients a mononucleosis-like syndrome, so absolutely something to consider. We're in a current pandemic that can give you a rash, COVID. Yeah, you'll see, don't worry. So COVID can give you a rash, a lot of different types of rashes, but one of them is as people get better, they can get actually a macular papular rash. And how about a patient who, this may be more likely to be petechial, but it can be macular papular. They were exposed to ticks, they were outside, and they come in with myalgias, headache, and they have a rash that also includes their hands. What would you consider?
Rocky
Yeah,
Mountain.
so absolutely. So that's something to definitely consider in these patients. It's going to be your rickettsial stuff. So that really includes, Rocky Mountain spotted fever is a diagnostic imperative that you really need to make sure you have a differential to start doxy early. Other ones, typhus can do it. Ehrlichiosis, anaplasmosis don't usually happen with a rash, but they can sometimes, so something to consider too. Those are your big ones. Spirochetes can do this sometimes, like leptospirosis, but I think having this on the differential will get you to most places for a macular papular rash. So based on your differential, what other information do you want for this patient?
What are her meds?
So meds. So I give you that. I had just started her on colchicine and allopurinol about 3 weeks before this. Other meds were like lisinopril for hypertension and atorva for her hyperlipidemia. Those have been on for a long time. Anything else? I didn't really give you much of the history on purpose. The travel, and that's something I didn't mention, like dengue and chikungunya can develop this rash too. No travel though. Good, very good question. And I'll just give you a general review of the system. Before I give you that, I'll just give no sick contacts. And then review his system. The rash was really itchy, but she really denied any any really other manifestations. So no constitutional symptoms. What would your guys' red flags be? Things that you want to look at, things that you want to ask to make sure this isn't something scary?
Any oral symptoms?
Mucous membrane.
Yes. Yeah, so mucous membrane. The thing is the way I think about asking red flags for these type of patients is, what are the oh, what the hell? 1 second. So what are the manifestations of SGS and DRESS, right? So SGS, I think you got it. These patients will come in and they'll have, so initially, actually it's kind of crazy, these patients will have kind of flu-like symptoms. So they'll have this flu-like prodrome, and then after they have that, they'll start developing symptoms of mucositis. So they may have like eye pain, they may have odynophagia, and then they get skin pain, and then they get blisters. So if you ask this and you see any of these things, especially early on, that is something to take very, very seriously, because the earlier you remove the drug, the more likely they're going to have a good outcome. So these are things, when you see someone with this rash, to really make sure you're ruling out something scarier, right? How about DRESS? What are the things that you kind of worry about? Or what are some of the red flags of this? I don't remember.
Liver involvement, but I guess.
Abdominal pain.
Yeah, so liver involvement for sure. So you may not have that initially, but really just like end organ changes, end organ dysfunction. So a lot of things can happen with DRESS. I mean, the biggest one are like LFT abnormalities, acute interstitial nephritis. So those are the ones you think of. But other things that you worry about too for DRESS is things like lymphadenopathy, erythroderma. So really, really violaceous, confluent rash all over their body, and pharyngitis and facial edema. So luckily she didn't have any of this. And we kind of, what do you guys think happened here? What do you think is the most likely diagnosis for her? And which drug specifically? Yeah, so we thought this was allopurinol. And I'll go into management a little bit later. But I think the next thing that I want to do is just kind of go over all the different drug reactions that you can have, because it is a ton of them, and they can manifest in a ton of different ways. So, I mean, the first one is going to be anaphylaxis, probably one of the more common ones, or not more common, but probably the most scary ones. I mean, this is emergency. These patients can get hypotensive, hypoxic, stridorous, wheezing. And the meds that you really worry about here is mostly going to be antibiotics. And it's the typical offenders every time: cephalosporins, penicillins, sulfas are definitely the things that you worry about. Kind of on that diagnosis is also things like allopurinol as well, anti-epileptics. The next one, and you may have seen this once or twice, is going to be your type 2 hypersensitivity. So this is going to be basically these drugs usually, here's a drug, they usually form a hapten to something else, and then they have direct antibody-mediated reactions. And a lot of times the things that are going to be destroying these type 2 sensitivities are going to be red blood cells and also like platelets. Does anyone know some of the typical manifestations that give you like drug-induced hemolysis? What's that?
What do you mean?
Yeah, which drugs are the common offenders that can give you like drug-induced hemolysis?
And like platelets,
Yeah, yeah. So platelets for sure, those PGY12, so like the G2B, 3A. And this is something you'll get. It's like a patient comes in NSTEMI, high risk, they're treated with like apixaban or tirofiban, and then they develop really bad thrombocytopenia. So that's definitely a board question too. I'll just give you guys this one for hemolysis. Actually, the biggest offender was cephalosporins. Almost like a third of cases were secondary to cephalosporins, then penicillins, and then after that, it's NSAIDs. NSAIDs are like always kind of on the differential, and then sulfas. For drug-induced ITP or drug-induced thrombocytopenia, the ones that you're going to worry about is all that, plus these G2, 3As, Vanc, and heparin. So definitely something to worry about whenever you see hemolysis, ITB. Look at the drug list, see if any of the medications they're on are common offenders, and definitely have that on your differential for whether you need to stop that medication. The next one is going to be your immune complex, like a type 3 hypersensitivity reaction. So this one is secondary to basically immunoglobulin attack to specific antigens, and then they're subsequently deposited throughout the rest of the body. Usually it goes to like the skin, and these patients can get like urticaria, and commonly it'll go to the joints, and these patients will get like arthralgia. So they'll get these urticarial skin lesions, they're the joints, and they'll get arthralgias as well. The typical ones that will do this, does anyone know what medications typically causes like serum sickness-like reactions? They're kind of a group of meds, and they're larger molecules, and that's why they do it. Yes, MOABs, yeah. So MOABs are your typical offenders. Doesn't happen that much because I think they've gotten better at making MOABs and making them like smaller, so they don't elicit such strong immune reactions. But typical ones are rituximab, infliximab, things like that. So absolutely MOABs. And then when you get to this macular papular-like reaction, this is really going to be secondary to type 4 reactions. So these are T-cell immune reactions. So these are secondary to basically T-cell immune attack to your body, and that's what causes these rashes. So these can be further divided. I wasn't sure if I was going to go into this, but I like pathophys, so I'll teach it anyway. These can be further divided into subtypes of different T-cell immune reactions. And the major subtypes that we're worried about in these drug-induced reactions are going to be your type 4B, which is your kind of atopic eosinophilic subtype. And this is why patients with drugs have a little bit of eosinophilia. The other one that it kind of comes into is actually like the CD8 T-cell immune reaction as well. So these macular papular reactions are like a little bit of mix of both of them. And the way that they really happen is that, so 4B hypersensitivity, this is your eosinophilic response. Usually drug reactions are going to be more like in this category, which is why drug-induced macular papular rashes are more itchy, and they usually have elevated EOs. So those can be really kind of clues that when you see a macular papular rash, it's more likely to be drug-induced versus viral-induced. Is the presence of a little bit of eosinophilia and the presence of like really pruritic. So the way that these kind of occur is that, you have your APC, like a macrophage right here. It kind of takes the drug, usually attached to like a hapten, and it presents it to the CD4 T cell. The CD4 T cell then basically creates IL-4, IL-5, subsequent eosinophilic inflammation of the skin, and also neutrophilic inflammation of the skin, giving you that typical macular papular rash. Viral drug eruptions are going to be a little bit different. So usually viruses actually cause the keratinocyte itself to take up this antigen, and then subsequently a CD8 cell, like your cytotoxic T cells, go and destroy those keratinocytes. So usually on biopsy, you're going to see all these like little apoptotic keratinocytes, and these patients are less likely to have eosinophilia with these viral reactions, right? When you see a virus, the first thing you don't think about is eosinophilia, and this is why. It's more likely the cytotoxic CD8-like reaction. And usually uses granzymes, perforin, to destroy your keratinocytes. So these things, and when I think of drug reactions, I really think of them as a continuum. Now we think about the kind of low-risk drug reactions in macular papular rash, but if you think of this type 4B hypersensitivity as a continuum, and when this gets very severe, it turns into DRESS. And that's why with DRESS, you have eosinophilia, right? That's that's in the name. And then when you have a drug eruption that's very severe and it's kind of more on the 4C hypersensitivity subtype with apoptosis of the keratinocytes, do you know what you usually see? What kind of drug eruption that will be if it's super severe? Yeah, so SGS-10. So when this gets very severe, it's SGS-10. These kind of are on a continuum, and a lot of the drugs that cause macular papular eruptions, the one that we went over, can also cause DRESS and can also cause SGS-10. The other thing I like about kind of going over the pathophysiology, it makes you think about why certain HLA subtypes are predisposed patients to these hypersensitivity reactions. So there's a few of them that we know. One of them is allopurinol, and specifically, it was like 1508, HLA-B 1508. You actually always have to test anyone who is Han Chinese or Southeast Asian before you start them on allopurinol, or else you put them at risk for SGS and also DRESS. The thought process is for some reason that their HLA, this kind of HLA molecule here, induces a conformation that when it binds antigen, it's more likely to elicit a severe immunogenic response. Anyway, the other one that you have to think about too is carbamazepine. And you'll also have to test these patients too. Similar demographic, Han Chinese, Southeast Asian, before starting these meds. So something to really worry about, that anytime you're about to start an anti-epileptic or you're about to start allopurinol in the patient's Southeast Asian, you really want to test these HLA subtypes, because if they're positive for these HLA subtypes, much more likely to develop a severe immune reaction. All right, so we get back to this lady. She's diagnosed with macular papular eruption, no high-risk features, likely starting allopurinol. So the question is, what is your next step? So A is continue allopurinol, do some oral pred. B is stop the allopurinol, start oral pred. C is stop the allopurinol and just give supportive care. And D is continue allopurinol and give supportive care. What do you guys think? All right, I got some C's. So C is correct. Yeah, so you're right. So C is really what you want to do here. And now can you tell me what your thought process is?
Well, I mean, it's when you said that they had no high-risk features, if you take away the offending agent, then the eruption should go down. Probably just with some like
Perfect, exactly. So this is kind of what you really need to do in these drug reactions. And then for extra credit, what is second line for gout? Does anyone know for gout prophylaxis? Decrease of uric acid. Yeah, so I started on febuxostat. She did well. So management, and I think you'll see this a good amount in the hospital, especially when the patient's on antibiotics and develop this macular papular rash. First thing you want to do at all times, rule out the scary stuff, right? So, and when you're doing that, just like Mark was saying, you're going to need a CBC with diff to make sure they don't have like severe eosinophilia. You want to do LFTs too to make sure they don't have some hepatitis from DRESS. Once you ruled that out, you can kind of go to the second thing, right? And the second thing is stop the patients all of their essential meds. I know I told you the highest risk med, but like any single medication that anyone is on can cause these reactions too. I mean, they're less likely, but if a patient's on meds that they don't need, they should never be on those meds anyways. So take those meds off. Don't worry about them. Just say, stop taking this med. I can't say for sure this is what caused it, but you have no reason to be on it anyway, so just stop it. Third, what Nam was saying, symptomatic treatment for the rash. So high potency topical steroids. This is like triamcinolone, fluocinolone, as well as oral antihistamines. And this one was new for me. I thought it was really interesting that when you're thinking about stopping what you think is the culprit med, there is research to show that you can actually just treat through. So if that medication is super important, so say someone comes in and they had like severe sepsis secondary to ESBL, and you put the patient on, you put the patient on, like meropenem, and they develop this rash to it. You don't have any other option, treat through. So actually continue that medication and then give them symptomatic treatment for their rash, because a maculopapular rash is less than a 1% mortality. So it's very risky to stop whatever the offending med is. You actually just continue it, and most patients will do okay. The last one, it's something else I touched on, is that you only consider steroids if there's severe cutaneous reaction. So DRESS, you'll do steroids. SCS10, kind of controversial for whether to give steroids or not, but at least for mix-up, it says most people will do like steroids plus like IVIG or plasmapheresis. Controversial, but that's usually what people do. And obviously those patients need like a burn unit, and you need to really think about how much losses they're getting. So they're probably going to need pretty aggressive fluid management, and then also really good monitoring for secondary infections. All right. I think this is the last one we have time for. So this patient, 50-year-old guy, presents the ED with rash. This is what I saw in medical school, actually. With rash, fever, and myalgias. The rash is shown, it's non-blanching. I forgot to take that out. The vitals are notable for fever to 101.5, heart rate of 95, normal blood pressure, and pulse ox. What would you guys call this rash? Not an uncommon rash that we see in patients. It's non-blanching, somewhat violaceous on the legs. Maybe it's palpable.
Was it a pediatric patient?
What's that?
Was it a pediatric patient?
It was not a pediatric patient, but I know what disease you're thinking of, and it's in that category of diseases. Probably. Purpura. Perfect. It's purpura. Yeah. So you see this, and what would be your differential for purpura? We're going to go through all the causes of purpura in 15 minutes. We'll see. So you were talking about one, right? What were you thinking of?
Like the head lock shirt. I forgot how to pronounce it.
Yeah.
Thank you. That one.
And,
Purpura.
which is in a category of like vasculitises, right?
Yeah.
So
So
that's
eosinophilia.
So that's absolutely one to think about. So vasculitis, and there's different types of vasculitis. There's your primary vasculitis, and your primary vasculitis are actually secondary to antibodies to neutrophils, which is what your ANCAs actually are, anti-neutrophilic antibodies. Those antibodies to these neutrophils then make the neutrophils degranulate and causing a ton of inflammation to the blood vessels, causing leakier blood vessels here, secondary extravasation of red blood cells into your dermis and epidermis, which is what purpura is, right? So there's kind of different causes of vasculitis, and I like to put this into two different groups. So there's primary vasculitis. So what some call it like primary vasculitis. This is the ones you learned in medical school for small vessel vasculitis. What do you think of? Yeah, exactly. So your P-ANCA induced, your C-ANCA. So for C-ANCA, God, I always get these like messed up in my head. But like granulomatosis, GPA, granulomatosis with polyangiitis. P-ANCA positive are usually going to be microscopic polyangiitis, Church-Strauss or eosinophilic polyangiitis as well. So these are things to consider, and they all cause this by neutrophilic antibodies that subsequently cause damage to your blood vessel and leaking of red blood cells. The second one, and this one is kind of confusing. So this would be like your secondary vasculitis. So vasculitis can really happen in a lot of different diseases, and these are usually secondary to like a type 3 hypersensitivity reaction. So usually it's going to be like antibody and antigen deposition in the blood vessels, secondary complement activation, and then basically more neutrophils extravasating, causing damage to the red blood cells, and subsequently extravasation of RBCs. Sometimes people call this leukocytoclastic vasculitis. And what that really is a histology term, meaning that there's vasculitis with neutrophils. But in this differential, there's a lot of different things I can call it. So what would you be concerned about is someone who comes in, IV drug user, has a transaminitis, and then has this rash? Yeah, so like hepatitis C, so infections can do it, hep C, endocarditis can do it, strep can do it. These are all in your differential when you see this rash, right? All right, and then I think that's really one of the bigger causes. The other one is drugs can do it. Same drugs that we really went over, penicillins. One that you'll see a lot, does anyone know when someone took, say maybe it's a patient who does a lot of cocaine outside the hospital, comes in with, levimazole. So levimazole is actually an antihelminthic that is used to cut, cocaine, and it can actually cause this vasculitis. So something to definitely consider, and always ask for, a drug history from these patients. The last one that I'll bring up here is going to be paraneoplastic. So actually about 10% of these tests, like these palpopurpura on the leg, it's going to be secondary to malignancy. And the reason why, cancers are as much of an immune phenomenon as they are a malignant phenomenon. And this is kind of what brought in the new realm of immunotherapy, is that increasing your immune response to cancers can actually get rid of the cancer. But for any cancer, your body is always fighting that cancer. It's always creating antibodies to the antigens that are present in that cancer. And unfortunately, a lot of times there's overlap with self-antigens and cancer antigens, so the body can then attack itself. So there is a lot of immune reactions that can happen paraneoplastically, and small vessel vasculitis is one. All right, so that's vasculitis. How about this patient here? So right here. So I'll give you a history on this. The person you say came in the CCU with diastolic heart failure, as well as VTAC. And the patient bears down and then develops this purpura around their eyes. What could this be a sign? They also have, let's say, hepatomegaly and a large stomach. What would you be concerned about? Yeah, amyloid, good. So this is amyloid. And this patient here, this is a very typical manifestation of the amyloid, is this raccoon eyes. So basically with amyloid, you have really going to be very fragile blood vessels. And that's in amyloid, it leads, it's actually secondary to deposition of amyloid fibrils in the blood vessel. And then when these patients say they Valsalva and they have a more pressure on these blood vessels, they can subsequently rupture with release of RBCs. So all of purpura is RBCs in the dermis, and sometimes it can be secondary to vessel fragility. This amyloidosis is one of those causes. So really on this differential too, with like fragile blood vessels, this is going to be a really tough one. So say this is I'll just make this one up. Say it's like a college student who only eats mac and cheese. And, what's that? Yeah, scurvy. Yeah, and this is actually follicular purpura. So it's a common cause of scurvy. Once again, scurvy is caused fragile blood vessels, collagen deposition, fragile blood vessels secondary to poor collagen synthesis. So that's absolutely on your differential for purpura as well. So scurvy, amyloid. We went through one, that's senile purpura. And the last one is going to be for for like fragile blood vessels is like ethers, Danlos, especially type 4. Not really too big a deal for us, or more for, you know, pediatrics. So those are all secondary to fragile blood vessels. The last kind of major category, pathophysiological category, is going to be clot. So say you had a patient who comes in with meningitis and they have retiform purpura, what would you be concerned about? They could, yeah, absolutely. That's something that Waterhouse Friedrichsen would come. Yeah, I think that was a poor question by me. Next year, I think when you were there, next year meningitis. I think I made it too easy for you, or too. Yeah, I think I made it too easy for you. So absolutely. So any of your TMAs can absolutely do this. So microvascular clots can do it. So TMAs. So things to think about: DIC, TTP, as well as HUS. And then also macrovascular too. So, I mean, anytime someone has emboli to the skin or endocarditis, it can absolutely cause purpura. This is called retiform purpura over here, and this is another dermatological emergency, because really when you see this, you know that the patient either has some sort of microvascular clotting going on, like DIC, or they have some sort of maculovascular phenomenon. So this is absolutely an emergency. If you ever see this, you really need to get to the diagnosis really quickly. So those are kind of all the causes of purpura. We'll go back to this. All right, so this guy, over time, this guy has purpura. You kind of check the labs for this guy. He has a creatinine of 1.3, his baseline is 0.8, CBC with a white blood cell of 11, and his UA with 2+ blood and 2+ protein and a transaminitis. So what do you guys think the potential diagnoses are in this case? A is Hep C, cryoglobulinemia. B is leukocytic vasculitis due to ceftriaxone. C is leukocyte-induced vasculitis, or D, all the above. Yeah, when it's all the above, it's usually all the above. If it's there. So this was kind of hard because we really didn't know why this patient had this rash, right? I mean, the patient had been treated with ceftriaxone a little bit ago, so that was on the differential. It's a common cause of patients getting a leukocytic vasculitis. This patient also did a bunch of cocaine outside the hospital, so that was on the differential too. So we ended up doing a further workup, and especially when you see palpable purpura, really what you should be thinking about is this category down here. It's more likely to be secondary to vasculitis, just from immune complex deposition. Will usually hang out in the legs just from, just because there's higher pressures there with like venous return. So anytime you see that, you really want to think about all the different types of vasculitis. So he was worked up for all of them. He got P ANCAs, he got C ANCAs. The patient got, hepatitis C, hepatitis B, complements, cryoglobulins, as well as an ANA and a rheumatoid factor too. And it came back that this patient had cryoglobulinic vasculitis, had an elevated hepatitis C, his cryoglobulins came back, his complements came back elevated, his complements came back low, and his hep C viral load was super, super high. For the last question of the day, does anyone know how this patient should be treated? Absolutely. So and the thing I want to really take home here is all of your secondary vasculitises, whether it's secondary to drugs, secondary to infections, secondary to paraneoplastic, treat the underlying disorder, right? That's the first thing you go to. You treat the underlying disorder, and then you only treat with immunosuppressants if that doesn't work. So I think for this patient, because he also did find out to have a glomerulonephritis, with this 2+ and 2+ protein here, he was treated with steroids and rituximab as well as being treated for his hepatitis C. So that's, I think, really the big take home is if it's secondary vasculitis, treat the underlying disorder. The two I didn't put on here is autoimmune. Autoimmune conditions can do it as well, especially if they're severe, lupus, Sjogren syndrome, but treat that. With your primary vasculitis, do you guys know what the usual treatment is? Steroids. N. Steroids and anyone? Yeah, so yeah, steroids and then like a B cell depleter. So typically cyclophosphamide, but now rituximab, especially for for granulomatosis with polyangiitis, is kind of, it has a lower risk profile, so it's a little bit beating cyclophosphamide, so it's probably used more commonly. But yeah, primary vascular disease, steroids, and then a B cell depleter, cytophosphamide or rituximab. So, all right, that's everything. We're not going to get the blistering. Maybe I'll do it another time. This guy has porphyric tantarta. And that's it. So take homes for you guys. The things I really wanted to cover today is use these descriptions to really describe your primary and your also secondary lesions. And using them together is going to be much more helpful to giving someone like a very clear understanding of a rash when they can't see it. Knowing cutaneous manifestations of systemic diseases is something that's very big for internal medicine and very big on the board. So knowing that the derm manifestations of HIV, I think is pretty big. Molluscum, Echinus psoriasis, sepderm, Kaposi's, Bartonella. Maybe not testable, but I think this is really helpful. Any pruritus without skin lesion can be a sign of there's metabolic disorders, endocrine disorders like hypothyroid, or even lymphoma. And then anytime you're looking at a macular papular drug rash, always look for those red flags, right? That's going to make you kind of change your differential and change your management. So look for mucositis, look for bullae, look for skin pain, for SGS. And for DRESS, look for those systemic symptoms, erythroderma, lymphadenopathy, pharyngitis, LFT changes. Last one, I mean, I think when you think of purpura, think of vascular causes, right? So when I was kind of going into that, I should have done this, too much stuff. When you're going into that, really just, I like to think about it in these categories: vessel fragility, clots in the vessel, or inflammation of the vessel, and thinking about your differential diagnosis secondary to that and what they look like. Any clotting of the vessel is going to look more usually like retiform purpura. Very scary, means that there's something underlying very serious going on. And usually any inflammation of the blood vessel is going to give you this palpable purpura, more likely in the legs. And then the last thing that I'll go, you don't get the last thing, I forget what it was. The last thing is, oh, you know what? We didn't cover that anyway. Does anyone have any questions? That was a lot of material. No? All right. Thank you.
Bye, everyone.
Yeah.